So hopefully you're in the right place. We are in the session on policy, so statewide initiatives in response to the pandemic. Richard Pan is going to be our moderator and panelist and play two roles throughout this. And we also have Kelly Pfeiffer and Alice Chen joining us. So I will, so a couple of tech things, if you can leave yourself on mute if you're not speaking, that ensures that we can hear everyone as they're speaking. If you have a question, if you can put it in the chat, and we'll try to get to questions throughout the session and have some time at the end to take those. Thanks so much. And Richard, I'll hand it over to you.
Okay, thank you so very much, Renee, and it's great to be here with everyone. I'm Dr. Richard Pan, cohort 5. I see some of my fellow cohort mates on this event, and it's great to be back with all of you. And I'm pleased to be the moderator for this panel we're having on how to shape policy. And really thrilled to have both Alice Chen, who's with the Health and Human Services Agency, as well as Kelly Pfeiffer with the Department of Healthcare Services, on this panel. And since they're both working for the administration, I think the organizers then said, well, you need to be a panelist too, not just a moderator. So I get to provide the other perspective from the legislature. But we want to basically share a little bit of our journey, leadership journey as policymakers, but more importantly, share with you how you could be more effective in helping shape policy, and from basically giving you our perspective from where we sit and our experiences as policymakers in the policy role. I will make maybe a brief comment before we get started. When I was getting my master's in public health, I did have a professor who looked at all of us and asked us, how many of you want to make policy? Most of us rose our hands. And then she glared at us and said, well, actually, very few of you ever make policy. We need you to implement policy. Other people make policy. But I know there are people here who do want to shape policy, and it is something people can be involved in. So we're going to share with you some of the ways you can shape policy, as well as implement the policy in your various roles here. So with that, again, really thrilled to have you. And we'll start off with some questions that we'll have with the panelists, and then take Q&A from you as well. So please, if you have questions, put them in the chat, and I think Kelly's going to kind of compile them, and then we'll get to those in the second half. So, so first of all, is sort of a way for each of our panelists to introduce themselves. Why don't you tell us a little about yourself, your current role, and how you shape policy, and maybe also your relationship with the leadership program. So maybe we'll just go in alphabetical order first. Alice, you want to introduce yourself and talk about your current role and how you shape policy, and maybe a little bit about your relationship with this leadership program.
Sure. Well, I'll start with the easy part. Thank you, Richard. It's so great to be here. And wish we were not on Zoom, in part because I'm a little technically challenged. It's like I'm trying to scroll through because I love seeing everybody's names and faces, but then I'm afraid I'm going to screw up my actual ability to see the slides and everything. So I was cohort 6, have just completed a year in Sacramento. So I'm currently Deputy Secretary for Policy and Planning and Chief of Clinical Affairs for the California Health and Human Services Agency. And just briefly, I'll say I joined a year ago in a very, very different world. That was when we had a budget surplus. There was a newish still governor who really was interested in health and really interested in creating a California for all. Went there and led some of the agency's signature health policy initiatives around affordability, cost, and coverage, the Healthy California for All Commission, on which Richard is an ex officio member, the Office of Healthcare Affordability, generic drug manufacturing, which again, Richard, we can talk about that later. And then that was all in the works. It was signaled in the 8 pages. We were working on, trailer bill language and the budget, and then COVID hit. And so since March, I've done a really hard pivot and been pulled headlong into COVID, spend most of my time on that now. Initially, the nexus being ensuring that there was a waiving of any cost sharing for testing for COVID, which unfortunately continues to be an issue. But over the last, gosh, how many months has it been? COVID, I know, COVID days are like, dog years. It feels like a lifetime, but in the last 6 months, have worked on hospital surge. So stood up the LA Surge Hospital, alternate care sites, led our therapeutics task force, doing remdesivir allocation, CCP donation. We have a joint venture with the CMA doing our virtual grand rounds. Doing data analytics work. Many of you have probably heard about the snafu between the hospital data transitioning from the CDC to HHS. We were right in the middle of that, working with CHA to try to get data integrity and completeness as we were headed into our surge. And then a lot of public health policy. So was really part of the core team around the variance process and now the blueprint process. And right now, I think our 2 or 3 priorities are really around trying to fashion an equity measure tied to the blueprint, looking at how do we manage small counties, which I know many of you are in and realize, California is so huge, it's not really a one size fits all, and then vaccine allocation. So, lots of topics to talk about, but it's been a fascinating thing. The one thing I'll end before I turn it over to Kelly is, in the first few months of my time, in the first half of my last year in Sacramento, it really was around high-level policy and kind of shaping these big policy initiatives. The last 6 months has been really, I have to say, even more gratifying in the sense that it is the scope and the tie into actual implementation. Because for me, what's most rewarding is actually seeing a policy implemented. It can be very frustrating to create a policy that then gets filtered through the black box of the healthcare delivery system, and you never know how it actually ends up impacting patients. And I think in COVID, it's been really humbling and satisfying to be able to see policy actually hit the ground in short order. And what I would say to many of the people on this call is, in my mind, there's not really a divide. There's not so much of a divide between shaping policy and implementing policy, because personally, I think the best policy is one where you actually are iterating and you're kind of learning from both sides, because I think policy made in a vacuum oftentimes misses the mark. And that if you actually have some implementation knowledge and background to bring to policymaking, I think that makes for stronger policy. So I'm sure we'll have more to say about that later. I'm going to turn it over to Kelly.
Great, thank you, Alice. Kelly.
Great, thanks for having me here. So I was cohort 7. Many of my colleagues are here. I was a community clinic medical director, and at the time was very focused on integrating behavioral health, team-based care, population health, really like trying to make this ecosystem of a clinic work. And then I joined San Francisco Health Plan in a managed care arena, and was working with Alice and others on the implementation of Healthy San Francisco. You're trying to expand universal care for all and think about integration themes in the context of a county. And then joined CHCF, and then had 5 years there where we were really focusing on how do you work on integration statewide and trying to do it from the outside of the government. And it was really fun to learn policy from the foundation world, where we were really trying to influence government from the outside and then suddenly flip and be an insider. So I joined right around with Alice just over a year ago, and it was an exhilarating time because, again, mission-driven governor, deeply caring about behavioral health and healthcare broadly and healthcare for all. The legislature was all on board. We had a ton of money. And we launched this thing called CalAIM. And I think of CalAIM a little bit like trying to fix the Winchester House. Because one of the great things about California is we are always out the gate first. So, 1957, deinstitutionalization, we create a robust county-based mental health system. 1965, Medicaid passed. Within a year, we have a Medi-Cal program. We're trying to get as many people covered as possible. We implemented managed care in the early 80s in Medi-Cal, way ahead of the gate. We then did realignment, which gives mental health control to counties. And in 2014, we were first out of the gate with the ACA. And now, of course, we're trying to lead the way in getting undocumented immigrants coverage. But the challenge with being first out of the gate is that we've created a lot of structures that, like the Winchester House, are like adding different wings and adding programs and adding rooms, and they don't necessarily connect with each other, and they aren't, no one would argue that Medi-Cal is a seamless, smooth, reliable, robust system built on a great foundation. And we struggle with some foundation problems, like, you know, data systems and getting all these wonderful programs that were all created to solve problems at the time to work together reliably and seamlessly. So Cal-AIM was really aiming to say, we're not going to demo the house and start from the foundations up. We can't do that, right? We have a lot of law regulating how we built this house of Medi-Cal, but we certainly can think about what does the Medi-Cal of the future look like and what's the pathway there. And it's really a 10-year pathway. So Cal-AIM was the all-consuming until, you know, March, and then we switched to the pandemic. But what I think is exciting about this time is that we really are trying to use the opportunity in chaos. So with the pandemic, this issue of telehealth, that we were trying to implement telehealth for decades. You know, in California, I was part of so many hand-wringing sessions, including with many of you in this room, like, why does it take so long? It's culture, it's workload, it's technology, it's operations. And suddenly, like almost over a weekend, we did a massive cultural shift because we had to, and we did it with telework and we did it with telehealth. So I think that was one of the things that I love about state government is when you're outside of state government, you think of it as this mass bureaucracy that's really slow moving. And when you're inside, it's the fastest paced job I've ever had. And I think some of it is circumstantial because of Cal-AIM and then COVID and the need to respond rapidly. And this last thing I'll say before I turn it back is the other thing that really surprised me about state government is that we aren't in a, you know, kind of black box room by ourselves concocting policy that rolls out. We can't do anything without robust stakeholder involvement. I used to think robust stakeholder involvement was one of those phrases that bureaucrats say and they don't really mean it, but it's actually true. You know, we could have the most brilliant ideas in the world and we can't implement anything unless we get all of the players who are touched by that potential policy to work on it with us. And of course, it's much better because if you're trying to fix the Winchester House, every time you open up an electricity panel, you get surprised. So we can't actually do the work without having everyone who's touched by the policy weighing in and helping us co-design it.
Hey, Kelly, can I underscore that point, which is I do think, you know, having spent 15 years in San Francisco, there's a feeling sometimes that, oh my gosh, what is this, you know, fortress in Sacramento? And is anything I'm saying being heard? But you're exactly right. I mean, I think part of the issue is the scale of California is so huge, you know, 40 million people and so many different stakeholders. The truth is there's an incredible amount of stakeholder input. It's just that there's no one voice that rises above any other, really.
That's great. No, thank you. Well, since I'm also a panelist, I guess I should introduce myself too. So I'm cohort 5, as I mentioned before. So we have 5, 6, and 7 here. And when I was doing my cohort, I was at the time at UC Davis. I was the faculty member running the residency training program and also involved in many both community and professional groups. I actually ended up running for the legislature back in 2010 or 2009, 2010, because I was frustrated with the state government, the fact they couldn't pass a budget on time. I guess unlike my two fellow panelists, when I started in the legislature back in 2010, we had a $28 billion deficit. And just to put that into context, that was representing almost a third of our general fund at the time. So imagine, and we're also required to spend a certain portion on K-12 education, which isn't necessarily a bad thing, but there wasn't a whole lot of room to when you think about making cuts without really hurting people. And so that was my first experience in the legislature, was actually slashing programs left and right to try to balance a budget with Jerry Brown. And so in some senses, as we're sort of returning to deficit budgets, it's unfortunately a familiar place I've been in. I served for 2 terms in the state assembly. I actually chaired the Assembly Health Committee at the time, and then got elected to the state Senate. I should probably mention just very briefly, since this is an election year, I know this is a totally not-for-profit thing, but I was actually, when I ran, I was the only Democrat to take a Republican seat in a state or federal election in 2010. Tells you how what most competitive races in the entire state at the time when I first got elected. When I ran for the state Senate, actually, I again was one of the hottest seats that I had to run in elections that year. It was a Democrat on Democrat because it was a top two serving in the state Senate. Now, one of the reasons I mentioned this is that unlike my two panelists, I actually have to get elected. So that's a whole different dynamic when you think about the role. And I think anytime you talk to an elected official, just realize that they're not an elected official unless they're elected. So to keep that in mind, all right, if you want to keep your job, just think about all the things you do to keep your current job. The most fundamental thing that any elected official has to do is be elected. And so that is something that always has to be in the back of your consideration in terms of everything you do if you want to stay an elected official. I would also, now that's not necessarily a bad thing. That's what's called democracy. All right. I know sometimes people view that as, oh, that's not a good thing. So my current role actually is fairly unique. And actually, so I chair the Senate Health Committee, but I also chair the Senate Budgets Committee subcommittee on Health and Human Services. So I have both the policy committee and the budget committee together. So I guess I oversee both sides. Most of the time it's two different people. And so that's been an interesting place to be in terms of shaping many of the health decisions that come out through the legislature. Unlike my two friends are on the panel, I don't get to do as much of the implementation. My job is oversight. So my job is to ask questions, to say, how are you doing this? And actually to also allocate the resources. So one of the most fundamental powers of the legislature is the power to appropriate funds as well as to write laws. So we certainly play much more of a role in the policy shaping and the resource direction. And then implementation is left to the administration, and then we get to critique it and then pass more laws and either cut or raise budgets accordingly. So, but certainly as an elected official, we certainly hear from lots of stakeholders, both in our districts and throughout the state. And so certainly they have a very important role in shaping policy. And I guess I would just comment that before, actually, when I was doing my leadership program, I actually did serve on a county commission, the first 5 commission. I was appointed, but I did learn quickly that when you're spending public money, you have to talk to everybody. You can't just spend it. I mean, sometimes people try, but it doesn't usually end well if you don't talk to all the stakeholders. And when I say all the stakeholders, that means whether you agree with them or not. And I think that's another important thing. And then finally, I would say is that I think all of us in the leadership program, oftentimes many of us will say, well, why don't we just have some objective people share the facts and the policy and so forth. In politics or in the legislature, and frankly with the administration too, everyone has a political agenda. All right. I mean, you could be a white hat, you could be whatever. Everyone has a political agenda. And I think that one just needs to recognize that. So when you come in, you may be coming in with all the best intentions, but that does represent a political agenda. And so when you're trying to shape policy, just be very aware of your own political agenda that you're coming in with, and recognize there's people with other agendas as well. And so that's something else I just wanted to point out. So with that, I think we'll move on to our next question is, well, let's talk a little bit about the dynamics. We talked about stakeholders. Let's talk about the dynamics between stakeholders and the governor's office and the agencies that you're in. So I know we touched a little bit on that. So I don't know, Kelly, do you want to start off with that? You're sort of the agency person at DHCS. I know you're also an agency as well, but do you want to talk about this dynamic between stakeholders, the governor's office, because the governor's an elected official, and Department of Healthcare Services?
Sure. I mean, it's interesting. And, I used to think hierarchy was a negative word. I've never been a very hierarchical person, but in order to have this integration agenda where, like, let's take foster youth, for example. Like right now, every time a child in foster care is moved from county to county, they have to change their health plan, then they change their county and who's giving them social services and mental health, and none of that works really well. So to try and create a better foster care system where we know that the kids who go into the system who come in with tremendous trauma, and we know that are very, very high risk for mental health conditions and physical health conditions, how do you create a system that works? So what we're trying to do, I lead behavioral health policy at Department of Healthcare Services, reporting to the Medicaid director and reporting then to the director. We need to work with our sister department, Department of Social Services, and come up with a plan. But we can't come up with our plan behind closed doors because it wouldn't work. So we created a foster care work group where we've pulled together stakeholders representing all the different components of the system that touch foster care. And we're doing probably it's gonna be about a 9-month process to try and design what would be a system that would really work for kids across the state. And then once we're able to have those recommendations, then we need to vet them through our lawyers and work with Department of Social Services. And then we bring it up to agency. And the Secretary of Health, Mark Galley, and his team, Alice Chen among them, would vet that and make sure it really fits with all the different departments that report to agency. Ultimately, nothing would work unless the legislature is on board. So we have to figure out what laws need to change and how to make sure that our policy recommendations are in sync with what the legislative agenda is. And so that may mean that, and ultimately we need the governor's approval to move forward. So some of the policy changes that we make might be a statute change, some of it might be a change in a waiver that we bring to CMS, some of it might be in the contracts or agreements we have with mental health plans and managed care plans. But again, with this metaphor of building the house, there's a lot of coordinating all the different architects and then the implementers. And so the whole point is that this hierarchy system that we develop really helps us, I think, make sure that we don't have cacophony of policies, that we really are trying to create policies that ultimately come from the bottom up and then make sense and then are implemented in ways that will work better than what we have now. Alice, do you want to?
Hey, Alice, I think, yeah, I think you're a little closer to the governor's office, perhaps.
Yeah, I would say, I mean, but Kelly, I think you described it so well, and it's interesting because I think, I don't have the benefit of someone like Richard who's been there for a decade. So I've only seen this particular administration over the past year. I will say, I think COVID is an accelerant on so many different fronts, but it also has been a positive accelerant in terms of really bringing to the forefront a kind of a common, shared focus on our underserved populations and collaboration and coordination across our different departments. So the agency works very, very closely with the governor's office. I mean, we're in contact with them, constantly, and really trying to ensure that, the policies that are put forward are coordinated with the legislature. I'm sure, Richard, you interact with TAM all the time, and then also with stakeholders that are coming directly to the governor's office. And then obviously there are a lot of different stakeholders that we work with directly. In the context of COVID, a lot of it is the healthcare organizations. So for example, we have a weekly call with the California Hospital Association and the SNFs and CPCA, CMA, the health plans, CCLHCO, CHCF. I mean, across all those organizations, I suspect that a good 75% of the people on this call have, been connected to one or another of those organizations. And then in addition, a lot of the advocacy groups like CPEN or Health Access, Western Center for Law and Poverty. And then we have all of the industry. So we have pharma and manufacturers and particularly in the context of COVID therapeutics and vaccines, coming to us as much wanting to inform us of what they're doing, as well as wanting to have an understanding of the direction that the administration is going in. And so kind of this idea of constantly, it's like radar, like a dolphin, like constantly pinging and seeing like what these different stakeholders are thinking about and their agendas, and trying to reconcile, engage, incorporate, challenge. I mean, it comes in all these different flavors in order to move the policy forward. Overall, I think Kelly's point was that the policy is richer and more robust for all this engagement. And I think that is true, even though sometimes it makes things go a little bit more slowly than I think we'd like. It is a really important part of the process.
No, thank you. Yeah, I would just say is in the legislature, so there's some different dynamics that go on. So first of all, the legislature is a collective activity. So what happens is that there's 40 state senators, right? I'm one of 40. There's 80 assembly members. We have 2 houses. Each house has their own leadership structure, right? And so when the legislature is acting, we have to collectively act. So the leader of the Senate, the pro tem, while certainly certainly can have significant influence, is dealing with 39 other separately elected officials. She cannot go and fire them if she is unhappy with someone. I mean, there are different things they can do, right? The speaker, again, has their house of 80 and whatever number in their caucus, and so has to balance the different demands and needs of each of the members. And then there's a relationship between the legislature and the administration. And I just want to comment now, here in California, we do have some people would term it one-party rule. So we have the legislature is dominated by the same party as the governor. So there's perhaps less conflict in terms of different parties or ideological conflicts. However, I would make note that we have we are different branches of government, and so there's always tensions between the different branches. And as I mentioned earlier, our job in legislature is oftentimes oversight. So as the administration is putting forward their priorities, we'll push back depending on what our priorities are. But also, it's our job to critique. In fact, actually, the press gets upset with us if we don't, go and critique the administration enough. And the public demands that we do that as well. So that sometimes can create some interesting tensions. I think one of the inside things that I should probably mention is that actually it's great that I'm right here talking directly with Alice and Kelly. But if they were formally meeting with me, they would have a minder with them. They would have someone from the legislative staff. For example, it's very unusual for me to have a direct conversation with someone in the administration who's in a decision-making role without having a legislative staff person, their legislative liaison, at the same meeting, on the same phone call, or something like that. All right. So they do try to put this distance between us to be sure that. And to be fair, it's also to be sure that because after all, we make decisions as a legislature, they want to be sure to have an accurate record of what's being said and what commitments are being made or not being made as well. Because as I said, each branch has its own power to do things as well. So I think when you go talk to your legislator, they have certain roles. If you go talk to the administration, they have certain roles as well. But the most effective people are ones who understand the various roles that people play. So then let me move on to the next questions, which sort of gets to the heart of this panel. Okay, so we have 2 people in administration, you have a legislator here. So how does this group of alumni then influence state policy? What's the best way to go about doing that? It may vary depending on what policy you're trying to accomplish, but I think each of us actually probably went into our respective roles because we're interested in doing policy, implementing or making policy. So maybe Alice, do you want to take this one on first? How do alumni influence state policy?
Yeah, I would say, my take on that is you can influence state policy from so many different vantage points and so many different arenas. I think, again, for me, like this divide between program and policy is a little bit artificial. Like a lot of policy is built on a successful program. And so if you're at a health center or at a hospital or community-based organization and doing something innovative and successful, like that's actually fodder for good policy to then say, how do we incentivize, scale, finance this type of program? So I think just, doing a lot of the great work on the ground, I think that's somewhat the premise of this fellowship is how do you take, clinician leaders who have kind of a frontline seat and insight into patient care in a multitude of ways, and then how do you then amplify that and connect it to policy? I think more specifically, I think there is the venue of bringing in your expertise. So if you're an expert, a content expert, you can do that as a researcher or an academic. And people will reach out to you to say, hey, can you give us input on this policy or help us think about how we should approach something. I think thought leadership, I know both Kelly and Michelle have been part of CHCF. I mean, CHCF is a big thought leader. So working for a foundation, and even we turn to them in terms of, was just talking about the need to, for example, get a survey out on healthcare workers' receptivity to the COVID vaccine. I think that's a way to influence how we approach vaccine allocation. And then I think the most, in some ways, sustainable way is to be part of an organization. I mean, I oftentimes think about two sayings, just in general, but particularly over this past year. One is, if you want to go fast, go alone. If you want to go far, go together. And I do think that there's only so much you can do as an individual, even if you're the world's expert in something, and that being a part of an organization that is organized and has a relationship with decision makers in Sacramento is a really effective way of shaping policy. I think the other pieces in terms of, I mentioned relationships, the other saying that I think of all the time is, change happens at the speed of trust. And particularly when things are in crisis mode, you do turn to people who you have worked with before and have trusted relationships and have come through on things to really to vet policy. So I do think both of those things are really important. I think another couple ideas, one is advisory committees. There are a multitude of those, and that's always an effective way to particularly get an introduction to state government and to get to know people and the structure and the processes. And then the last I would say is the way California is structured, it's very dependent on the counties. Right. So, I mean, at the county level, you may be sitting there saying, oh, my gosh, like what's going on in the state? But frankly, there are 58 counties and each county actually has quite a bit of say and a voice in Sacramento. And so I think being active, I think, as Richard said, on the county level, not only has an impact in your local community, but actually oftentimes has a direct connection to what's going on at the state.
Great. And I just want to emphasize that as someone who's in the state legislature, California very much.
Oh, I'm expecting a call.
Yeah, California very much has the county being the implementation arm for a lot of our health and human services activities. And in fact, every time we talk about issues in terms of how we implement mental health, and then when we bring Kelly on to talk about her role, et cetera, it's like, okay, well, each county is going to know what their particular position is and how and giving them the latitude to do that. So certainly don't just think state, think county as well. You can think both. So Kelly, well, why don't you elaborate then on
sure. And I can't resist that remembering that Bob Moore, before he joined Partnership, called me up and said, hey, just want to check in with you. How's that experience of joining the dark side, being, leaping from a community clinic to managed care? And he's influenced me too, because years ago he said, we all should join the state at some point. We should all do our job, take a pay cut, and go in there and try and make policy. And I always thought that was absurd. It would never happen. But then I never predicted that someone would come in and have this big change agenda. So number one, think about joining us. I'm actually recruiting a key role that will lead behavioral health policy with me if we're able to move forward on CalAIM. So if you're interested in behavioral health, there's a great job available. Second is that if you can't join us, and you're going to stay on the outside, look for trains that are moving or about to move, because so many of the great ideas that you have will much more likely move if there's a particular moment in time. So, we mentioned CalAIM. CalAIM is moving now because we have two different big waivers that are ready for renewal. And whenever you've got something that's ready for renewal, that's the time to get in there, take that document apart, and put in all of the good ideas that you've been waiting for years to do. And there's many more examples like that. If if you have an administration that's committed to something, the Senate and the Assembly is excited because there's something big happening that's triggered a need to make law. Like whenever you can build whatever you want to do on a train that's moving or about to move, it'll be much more effective. I would echo, and I just say that because I often get pitches from people about these great ideas, but there's no vehicle for me to put it on. And if there's a great idea and there's just no way for it to happen now with all these competing priorities, then it goes in the long parking lot. And I just want to echo what Alice says about looking for formal and informal ways, because there are a lot of formal ways you can participate in task forces and things like that. There's the informal ways of being a trusted information broker. So we know that if we come to you, we can quickly get information we need. And in the prep call, we talked about what it's like when you're inside the state getting a pitch. And how different it is to have someone come and talk to you for a half hour and use 29 minutes of it to push really, really hard why their idea is so good. That almost never works because there's no way for me to engage and think through how could I actually make your idea work in the current environment with all the competing priorities and the vehicles that are moving and not moving. The best pitch is where you might use 15, 20% of the meeting to say, this is the important idea, this is why it matters, and then start asking questions. What vehicles could this be attached to? How could this happen? Who would be for it? Who would be against it? What is the momentum that this could join? So again, thinking about when you care about something deeply, listening more than you talk is more likely to get your idea moving. And then I think the last comment would be, don't underestimate the staff, because whether they're Dr. Pan's staff or they're the staff on my team, like they're the ones that are doing the work, they're writing the words. And in state government, especially in Medi-Cal and public programs, it's words that matter, because it's the words that ultimately the lawyers will look at when they decide whether you can do what you want to do or not, or whether your risk management people or compliance people let you do what you want to do. So the words and the details matter so much that building the relationship with the staff who are actually going to execute the policy and write the words really counts.
No, great. Thank you, Kelly. And those some really great examples, and it's a great transition to our next question. So I'm going to sort of tee it off by starting first on this issue. So, when it comes to trying to influence state policy, one of the things that I often tell people is that we look for sort of windows of opportunity where certain events happen. I guess we can talk about COVID right now. We can talk about the raised awareness of around racial discrimination and racial injustice and structural racism right now. But there are different times when there are windows of opportunity to open. They don't stay open very long, I would point out, where there's a possibility for change. And what I try to share with people, though, is that the reason things happen is because the people who are interested in making the change have been preparing for it. Okay, because as I said, when the window opens, there's usually not a lot of time you just have to jump through. So I'm going to just share, for example, is the vaccination bills that I did, right? In fact, in 2015, when I was first elected to state senate, some of my colleagues came and said, hey, one of my colleagues came and said, I want to do a vaccine bill. And I said, no, not yet. I'm not sure this is the right time to do it. And then we had a measles outbreak that started spreading through the state. And then so as the measles spread, he said, well, is it time to I want to do a bill. I said, well, I'm not sure we're quite time, because it was just starting. I wasn't sure how big it was going to get. And then finally, when we got the secondary transmission, I said, okay, we're going to do a bill. And he said, what made you change your mind? I said, well, we now have a narrative where the measles is now spreading to people in the community beyond Disneyland, from people who are there to other people. So we're not talking about an outside virus coming to our state. We're talking about virus spreading within our state. And that was the window of opportunity. But we had been sort of prepping and thinking about, well, when would be the next time, when would be a time to actually have this conversation about vaccines? Because I had passed a previous bill a couple of years ago to try to address the rising non-medical exemption rate. And so these windows of opportunity happen. I think I appreciate Kelly bringing up a Cal AIM, because what happened is that we actually, well, several things were coming at the same time, right? So we had a situation where we had our waivers coming up. We knew we were going to have some challenges with this particular administration, the Trump administration. We also knew that the procurements for the commercial plans was coming up. There's several things all coming together. Plus, I think the people in place were very interested in thinking about, well, how can we better streamline and reform Medi-Cal, right? At the same time, and certainly I know that at that time, the DHCS director had come to me and talked about, well, we should think about, and then we had a new governor who said we should think about how do we make Medi-Cal work better with particularly some of other social service programs, particularly dealing with homelessness. So these things all came in the line. And I think that as people want to try to influence policy, I think is what Kelly said is that oftentimes there's a couple things you need to do. One is recognize, like, when are these potential windows going to open? Like, what forces are in play? And you know what? If you don't know, that's fine. That sort of goes back to what Alice said. I mean, you're part of a larger organization like CMA or the Primary Care Association. They have folks who actually could probably help you. They have GR folks who can tell you, like, hey, these sort of things are coming up. So you do need to ask questions, do your research about that. And then, or actually, you know what, when you have your meeting with someone like Kelly or Alice or me, you said, well, this is what I'm interested in, as Kelly said. What do you think is the best way to go about doing it, right? And we'll say, well, I don't know about right now, but maybe when this happens, there's an opportunity to tack it onto that, right? So again, that's a way to figure it out. And then the other thing that I think is also important is coalition building, right? I mean, we talked about it's really hard for one person to take anything further, and then an organization perhaps to take it a little farther. But again, the broader the coalition, and let me just say something as someone who's elected official, we really hate having to choose sides. I just put this right up front. So I know what it's like on the administration side, but I'll tell you, if you're an elected official, you really hate to pick sides. So the best solution for you is like, hey, all you guys, you have a disagreement, go into a room, work it out, tell me what you all agreed on, and then I'll go and push that, okay? So to the degree that you can build a broader coalition and show that, you know what, we pretty much have everybody, except maybe if there's someone who's a holdout, then that's going to be a much better place to be. Ideally, you have everybody on board. In fact, usually what happens is if you have enough people on board, the minority side sort of figures out, okay, if you agree to this, I'll give in, because at least now. So as much as you can do of that, actually, at least on the legislative side, I think helps out. Frankly, my guess is, and we can see what Alice and Kelly think, but my guess is that the governor's office likes that as well. So I know there's times you have people just like, okay, I'm for and against, and we have to pick sides. But frankly, as much as we can try to do, I always say, as much as someone can neutralize the opposition, you don't have them on your side. Just say, okay, I'm neutral, I'm not opposed. That is significant. That is always very helpful. So I'm going to leave it at that. And I don't know, Alice, do you want to comment? Or Kelly?
Like one classic
Kelly.
example is in the middle of the emergency, everyone says, Mental Health Services Act funds, we need to be able to have flexibility. And, a dozen different letters arrived at the governor's office, CCing to us with all different points of view. And so, I was trying to get something moving, but I couldn't because everyone disagreed with each other and they'd all sent in these individual letters. So kudos to the behavioral health directors. I think there's a couple on the call now. They got together, they got all of the different letter writers together, and they closed the door and, hammered out a compromise, and they were able to move something forward. But again, even if you're not elected, you don't like to choose sides when each of those sides are really important partners in the work you're trying to do.
I can't agree more, and it makes me feel good for a seasoned person like Richard to put his finger on it, because that's been absolutely my experience. And it actually makes me think back again. I think there's this whole continuum of kind of organizational management principles actually are the same at a policy level. I still remember when I was a fellow, one of my co-fellows shared with me a form that he would give to his direct reports when they came to him with a problem, and ask them to go back and figure out what are the solutions, who are the people you can work with, and then come back to me. And so I think to Richard's point, like when you actually have particularly uncommon bedfellows that have worked out some of the initial disagreements and come not initially as a united front, because there's never going to be 100% consensus, but like agreement on the fundamentals and a willingness to compromise on some of the others, you can move pretty fast, pretty far. But if you're actually just coming at the administration with your own agenda and haven't talked to anybody else and don't even really know what the landscape is, it's just not going to go very far. Yeah. So I couldn't agree with you more. I've seen it multiple times now in one short year.
Yeah. All right. Well,
can I just though also just add on that I think this idea of a policy window is so critical. I mean, I definitely think, to Kelly's point, finding something that's moving and trying to attach to it, even, if it's only peripherally related, but many of us have been, passionate advocates of something, whether it's behavioral health or homelessness or, immigrant health or disparities, and a window will open. And I think, to Richard's point, being apprised, like keeping tabs on when that window is open and then really pushing hard at the time. I do think with COVID, clearly all of us know about telehealth. I will say that in general, synchronous telehealth is a bit of a snore to me. It's like, great, you have 2 videos. I mean, not to diminish the lift it takes for underserved populations in particular, without having universal broadband, without having access to, smart devices and all that stuff. But going even further to things like hospital at home or home-based monitoring and registry and population health, like I think this is a time for us to really push on that. I think the other piece is disparities. I mean, clearly between the racial justice movement and COVID, there is an attention and a receptivity now that I don't think has been there in all the decades that I've worked on disparities. And I just feel like it's incumbent upon us to really come together and figure out what is a path forward to really make some tangible changes on this front.
Yeah, if I could leap on that, I mean, it's really exciting for us to have a new Department of Healthcare Service Director who came in off the bat saying top priority is working on diversity and equity and inclusion, both internally and externally. And, I just want to call out J Africa because it's another example of where the department reaches out to our stakeholders, who are the behavioral health directors, and said, we have this project and we want your input. And what was great is Jay and his colleagues said, well, we're going to give you a lot of input because you've got a lot of things wrong, but we also want you to think bigger. Like this one project that you're doing is good to do, but you need to be really thinking bigger than you are right now. And so, of course, my answer back to him is help us, help us figure it out. What are the things that are going to not just attack attitudes, but are going to attack structures? What are the things that we should be tackling? Because now is the window when we have the attention across the state about the importance of this. And we wouldn't have been able to move so fast a year ago before all of the national dialogue happened. But I think there's moving track now that we could move on, but inside the state we've got so much to do. We're not going to have all the best and brightest ideas. So having others come and say, this is something concrete you could do. And we have actually thought it through some about what vehicle you could use and what it would take to make the change. And is this a legal change or a policy change? Or is this something you have to get CMS's approval for? All these things are helpful when you come to us with your ideas.
Okay, so that's wonderful. And I just, maybe one other comment from my perspective is that I would point out that as a legislator, if you look at my office, you go, oh, look, you have all these staff, et cetera. Actually, we don't have that many. Most of them are dedicated to doing things like, constituent services. We're helping a lot of people out with their employment. So that's about half of my staff. I have a press person that has to work with the press. I have, some leg staff to help move the bills, but I don't have a staff of analysts that can go take a data set and figure it out. I mean, they can read a report that someone else did. So having those types of resources, I know the Healthcare Foundation often plays that role, is something that's very important. We do have a legislative analyst office, but actually their budget's somewhat constrained by, some constitutional limits on how much the legislature can actually allocate funding for itself. And so groups that can come in and provide analyses are very important. But I also want to point out that the most effective people who come to the legislature, advocates, are ones who can not only talk about their own side, but can also talk about the opposition's objections, right? So that is something that I also want to mention as well. Now, obviously, it is the role of the opposition to talk for themselves, but to be able to point out and to show that you actually understand what their problems might be and what your counter might be as well. So with that, I want to be sure we move to our Q&A because we think we've run a little over on their questions here. So please, if you haven't already, if you have questions for us, please get them in right now. And Renee, do we have any questions yet?
We don't have any in the chat. Another option might be if people have a question that's come to them, we could invite them to unmute and ask it to the panel.
Sure. Yep. All right. Actually, everyone knows about the raise hand function. You put the participant list, you hit participant, and you see underneath invite, mute me, raise hand. If you raise your hand, I can call on you. If someone wants to ask a question. Oh, come on. This is not supposed to be a shy group. I thought this was a leadership group. I know you are. Okay.
Okay, this is Betsy. I do have a question. I know we talk a lot about your relationship within the state. I'm curious to find out, how do you collaborate with federal level? And I give you one example. We're struggling. Department of Healthcare Services, send out APL, say, you know what, our member are not getting in for preventive service due to COVID, right? Because there's fear of going to see doctors. So they really want us to have a call campaign to reach out to our members, especially for children, to get their immunization before school start, and also for senior before the flu season start. So we were all ready to go. We got our robocall ready, texting, but then boom, we find out that the state's directive is directly in conflict with TCPA, Telephone Consumer Protection Act. So we came to a screeching halt, literally, because our legal say, hey, no way, you guys cannot roll out outreach campaign. It's against a federal law. You gotta be taking these action first. But for Medi-Cal, with a Medi-Cal plan, so our challenge is the state gets the telephone from the member, and there is a legislature saying they can only use this telephone number for eligibility determination. So it's not like they can pass that prior express consent to the plan that we can go ahead and move forward. See, this is something that literally we will be against the federal law if we went ahead and followed the Department of Healthcare Services directive. So we're struggling. I mean, I'm having a call with all the local plan. What is your strategy? And all the legal have different interpretation. How much risk tolerance? I'm thinking, wow, won't this be something that the state will vet it with the federal law first before they rolled out, all plan letter directive to the health plan? So we're struggling with pedaling backwards, but guess what? Our members being harmed because we cannot roll out the call campaign as we originally planned. Okay. We're still back and forth with the state. Okay. So I'm seeking your guidance. Is that somewhere in the state branch to say, hey, we're gonna roll out this policy. Are we making our constituent breaching a federal law before it's rolled out?
So, actually, I don't know, Alice, did you have some comments about that? Or,
and I can take it. It's
or you want to take it? I have some comments too, but I figured.
So why don't you go first, Dr. Penn?
No, I mean, so we do have a, we have a federated system, right? We have federal law, we have state law, actually, and then we have local, right? So of course, and frankly, yeah, there are challenges because also there's potential different interpretations, right? So you talked about, the legal team, et cetera. And that's, by the way, that's why Attorney General Becerra's filed how many lawsuits now? I think it's 50 or something. I forgot the number. I mean, we're talking against the federal government. And so, there are these differences. There are, issues of interpretation. I know that that's something that as the legislature, we've worked with, DHCS and the governor's office and trying to figure out like what we can do, what do we need state law for, but where do we run into the federal issue? And believe me, I've been on the phone calling, Dianne Feinstein's office and Kamala Harris's office and to try to get changes to see what, of course, unfortunately, they're the minority party in the federal government, but trying to see what we can try to do to figure some of these things out. And I know that certainly that's something the administration has done as well. And we even have discussions between the legislature and administration about, hey, what can you do and not do because of federal law? So yeah, that is something we have to work with and work around sometimes. Yeah.
Yeah, and I'll just comment. I mean, some of you heard me say before this saying of like, give me coffee to change the things I can change and wine to accept the things I can. And, it's kind of like a wine time sometimes with this administration. And some days I'm blown away by the flexibility and leadership in the federal government. An example was really early on, we were pushing the DEA and SAMHSA to allow buprenorphine prescribing by telephone and to allow methadone clinics or, narcotic treatment programs to give week supplies or month supplies so people to go into withdrawal. They turned on a dime. Like I was shocked that I could email Ellie McCants-Katz, the head of SAMHSA, and she responded to me at 3 a.m, says, yes, we're on it. We're going to make it happen. We want people to get their treatment. So sometimes I'm surprised the level of influence California can have with the federal government. And other times we get stopped short, and we get stopped short in ways that don't make sense, because we would say any rational person, if you can get them in the room, would say you should be able to text your members and phone and do robocalls and do anything possible to get them the help. And we come to a halt against some federal regulation that someone in federal government feels is not changeable at this time. And to be honest, anything that is in statute in the federal government, trying to get 2 houses to agree on anything to change, it's really, really frustrating. So I feel your pain, Betsy. I think that many of us would love to wave a wand and fix that problem. But again, I think there's so many things at the federal level that because of where we are in this administration and the kind of gridlock between the parties. But nevertheless, we have more influence than I could hope. We have good relationships with our CMS colleagues. We have really good relationships with a lot of our federal partners. And I found that they do their best to change what they can.
Let me just make one observation, and then we're going to move on to the next question, is that the issue of privacy and who has access to data is a very sensitive one. And the comment I want to make is, so for all us health professionals, oh yeah, I nod the head. But the other layer that also gets caught up is, for example, we have a very different position in California about trying to protect people who are undocumented than the federal government has. So I wouldn't be surprised if some of this might be caught up in this difference where basically we as a state are refusing to data share a lot of stuff with the federal government to protect people who may be getting services because they're undocumented. And sometimes they'll push back on us to say, fine, you're not going to share data. We're not going to let you, et cetera. So I don't know if that's happening in this particular circumstance, but there is this fundamental policy issue that's a tension between California right now and the current federal administration. So I think we have Bob Moore, I think is next.
Yeah, Richard. Yeah. Bob Moore from Partnership Health has a question.
All right.
Yeah, I had a question. As all 3 of you were talking about sort of the ideal of getting lots of stakeholder input and having everyone agree and making sure we don't implement or spend money without stakeholder. It strikes me, I can think of instances where that really didn't happen at the state level. It's different, and I'm not, I think, as I sort of ponder that, it's often related to maybe the individuals in charge of a particular department or who is making that decision. And what it strikes me is that while theoretically those values are there, they're not structurally there. They depend upon the people who are actually in positions of power within those different departments or organizations. And I wanted to have you sort of just reflect upon when what can be done to sort of mitigate that, to kind of keep moving us towards that ideal of multi-stakeholder input in the face of sometimes we're a person who has enough power and is not someone else isn't willing to move them along or whatever, has the ability to sort of promulgate irrational regulations. So what do you think?
So, well, I appreciate that comment. Actually, when I was first in the state assembly, one of the things I did push against the Department of Healthcare Services in general, Kelly doesn't have to defend this part, is that we felt that certain decisions were made without adequate stakeholder input. We heard from some stakeholders about some policy changes had to do, I think, with I think the initial rollout of coordinated care initiative and so forth. I would also, and so we pushed back on them on that. I would also, though, say is that I didn't really talk a lot about the budget process. And when we think about shaping policy, now theoretically the budget process is supposed to be just about money, but a lot of policy gets shaped in that. And that it happens every year, and we have to have a budget in the end. And while certainly lots of people try to weigh in on that, the decisions have to be made, and we have to say it's going to be this many dollars, and this cut or raised or whatever else. And so oftentimes, and then policy things get thrown into trailer bills to implement these budgetary changes as well. So so you're right. In fact, in those circumstances, I won't ask Alice or Kelly to have to comment on this. My observation as a budget sub-chair for Health and Human Services that oftentimes finance drives a lot of those things. And I know that each agency, even though I have the agency in front of me, they have to toe the governor's line, right? They can't go and say, well, actually, I disagree. We do need more money for public health, right? I got it. If you work for the governor, you toe the governor's line, right? They tell you what the line is, and basically you agree, and I don't make them disagree with that, but I may actually feel that that's not quite the same. And so that is part of the back and forth. And I think that, governor's office does have to make certain decisions in the budget, and then we make different decisions and we push back, and that's part of the dance. I mean, it happens with bills too, but you're right, probably, especially with the timing of the budget and the fact that, especially when you have a budget deficit like we have now, or when we had when I first came in, decisions were made, and certainly stakeholders who were affected negatively probably didn't feel they had enough opportunities to make an input. But it also could just be as like, well, we've decided, sorry, we got to do this because, in the grand scheme of things, this is how we make all the pieces fit together. So.
And Bob, to your point, I think everything Richard says is absolutely true. And I would reflect a few things. One is that state government is an organization like every other organization, and it's populated by human beings. And so the same dynamics of organizations and kind of organizational decision-making and the role of leadership, which I think, again, harkens back to the purpose of this fellowship, is critical. And an individual can potentially have a lot of influence based on their particular stance or approach or receptivity. I do think all the things that Richard was saying provide guardrails to that. And I think that there are definitely ways to move the policy agenda despite one or a few people's stance, but I think it just takes more effort if that's the case. To Kelly's point, I think one shortcut to that is to join the state government and play a role in being one of those leaders that can actually facilitate the direction that you think is right.
So actually, Kelly, go on. Sorry.
No, I mean, I think that some of it is structural, like big policy changes have to have stakeholder work groups. So some is built structurally, and some of it is just the realities behind the scenes. Like I respect our Department of Finance; they have to balance a budget, they have to weigh competing priorities and things I deeply care about, and that we've gotten the stakeholders' input on, and we think are going to sail through. The Department of Finance looks at it and says we can't make this all work in a tight budget season. So, but I guess that I think that's really the powerful of advocacy, that if you see decisions made that you think should have broader stakeholder input, just keep being the respectful, trusted, but persistent voice, because state government, I would say that folks in bureaucracy don't like to be embarrassed. And if they have someone respected on the outside saying, this doesn't make sense, we feel a lot of pressure to make sense externally. So I think one of the things I really feel like now that I didn't understand then is that folks in your roles are more powerful than you think.
So I guess the one other comment I want to make, and when Al said, well, if you want to help make decisions, join us in the state government, I certainly want to encourage people to do that. But there is a difference between advocacy and governance, right? So let me just share with you one of the most painful decisions I ever had to make in the legislature, which was actually when I first came in, because I served on my county First Five commission, and I knew exactly what we were doing with our money. I was on our finance committee. We had, banked our money in a way so that we could be sure that we had sufficient money to, in the face of a declining revenue source, to implement our 10-year plan over the 10 years, recognizing there's inflation, lots of financial sense, right? But that meant we had a reserve that we maintained. And then when the budget decision hit, I was basically told that, okay, well, and I was elected official, so they couldn't fire me. But what I was told is that if you don't vote for the budget, which basically called for the state to take away all the reserves First Five had at each county, then we will basically put you in a place where you can't, it'd be very difficult for you to influence further decisions. Basically, if you don't vote for this budget, the deal that we came to, the agreement we came to, that leadership came to, then, which included basically taking away money from programs you really cared about, then you won't have much of a voice in future policymaking. And so I had to decide, do I go along with the team? And by the way, it would pass anyway, because my vote wasn't enough to stop it, or not. And so when you're, that's the governance part. And believe me, I got lots of calls from First Five folks, including afterwards, saying, how could you betray us, blah, 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 et cetera, which really hurt. But the thing is, because I, recognize that maybe I can't win this battle and maybe can win a future one. Interesting enough, in the long run, that money was never taken away because some of us kept pushing back, but I had to make a vote to take it away. So, that is the hard part about the governance. I know many of you are in governance roles in your own organizations, have had to make those kind of decisions. So that is something to think about when you're coming into the fold, but then you also have a different type of voice that you can have with it from inside versus from the outside. I think both sides have ways of influencing, whether you're in the inside or the outside. But you also have, hard decisions to make too, and as well on both sides. So.
Richard, so we have 3 questions in the chat.
Okay.
First
Yes.
one is going to go to Susan Ehrlich.
Okay. Hi, Susan.
Hi, Richard.
Hey, good time.
Kelly and Alice, what an amazing opportunity to have all of you 3 together here. And so I'm going to use that opportunity to ask you about the future. So here in San Francisco, I think we've all been working incredibly hard to address a lot of things going on at the same time. One is COVID, obviously. The second is the really pressing need to address health disparities, especially those that are just laid bare by the pandemic. And then the climate change issues we're dealing with, the heat, the fire, the, apocalyptic conditions that we've been facing here. And the last thing that I don't think we've quite faced to the extent that it's going to be a problem is the recession. I think both at the state and the local level, we've had one-time reserves. We've been able to kind of skate through, but I don't think that's going to keep going over the next year or 2. And so you guys are there. You're going to be dealing with this. Richard, you've been there long enough to have been at a time when really hard decisions had to be made around the budget. How do you see the state addressing the inevitable recession with all of these needs kind of piling up at the same time?
Wow, that sounds like I should probably answer this question first, the group. So the challenge is that the state has to have a balanced budget. We can't finance into the future. You probably even saw some news stories. There were some efforts to talk about, allowing people to pay early and then giving them sort of a, break later on and so forth. There's an effort to try to figure out how we can finance into the future bit. So, that's a huge challenge for us in the state because we can't go borrow money to do our budget. And that's why we are basically trying to push the federal government as much as possible to do that, because it's the federal government that can do that. And we're looking for different opportunities to try to address the recession. Looking at unemployment, looking at other types of things. But no, that is a fundamental challenge for us at the state, recognizing that most of our spending is what I call counter-cyclical, right? The demand for it goes up when we have the least amount of money. And also our tax structure is one that's very volatile because we're very dependent on income tax, particularly from high income earners. And while one can argue that whether they really pay enough of their share, it goes up and down a lot, and that makes it very challenging. And in fact, we've banked a lot of reserves, and I want to again appreciate both Governor Brown and Governor Newsom for supporting it. And I've voted and so that's been able to cushion what we've had to do now, but it won't last for very long. So Alice or Kelly, do you want to?
Yeah, or not, I would just to reflect on the fact that, I think it's just unprecedented, the number of concomitant crises we have. As you pointed out, public health, economic, racial justice, climate, and frankly, leadership at the federal level. I mean, I don't think it's a partisan thing to say that the disarray, particularly around response to COVID, is really a failure of leadership. And I think it's really, I think it's impossible to say how we're going to do until we know what happens in November, frankly. And I think without significant assistance from the feds, I think we are all going to be in for a very, very challenging time.
Any comment, Kelly? And then we have a couple more questions, so I'm keeping track on time here.
I think you should go ahead. I mean, I'm in profound despair about the environment, and I don't know, we're going to have to do some deep adaptation. And so the main way I was thinking about, let me focus on the path ahead to take care of as many people as we can and do the best with what we have, and then learn to adapt as we go, because I can never have predicted where we are now based on my position a year ago. And I think it's going to be a long time before we ever get to what we call the new normal. And we may never get to a new normal. The pace change and the need to adapt to a rapidly changing climate and environment may mean that we're in a perpetual state of crisis for a long time. So I don't have a good answer.
Yeah, I just mentioned there are some propositions on the ballot that could affect the revenue picture a little bit. It's not going to make up for the whole. We need federal leadership. And then, generally the whole conversation about trying to raise revenue also is always a challenging one. It's not off the table, but certainly but fundamentally, I think without federal support, it's going to be very challenging. Next question is Alexander Lee, I believe. Is that okay? Thank you.
Hey, Richard. Thank you, three, for this great discussion and just incredibly insightful. Maybe I'll tee off what Susan asked to just ask you, Alice, you and Kelly, to forecast a little for us on where we are going to be with integration with more the social services, because I think social determinants of health has also been a big area of concern with this the pandemic and economy hit. And then Kelly, for you also with integration with behavioral health and substance use. And I think some of the challenges around both information sharing and so forth. So just love to hear your perspectives on those two future states or windows of opportunity here.
All right.
Well, I'm really curious. So, if you'd asked that question about telehealth, we would have said, let's take the behavioral health integration. We know that we're one of the few states that has a carve out that constitutionally counties are entitled to manage the mental health and STD benefit, and that any integration pathway, like what we've set up in CalAIM, is going to take years to implement, because we have to carefully figure out how to get voluntary collaboration between plans and counties and social services, and how we can best make these structures who were built from the ground up to be separate, how to make them work better. And some of it's a technology solution, some of it's a culture solution, some of it's a money solution. All those things are really, really slow. And I'm very curious if we would ever have a crisis that makes us operate at the speed of the pandemic, because I think short of a crisis, the existing system too painful to tolerate, we can get to integration, but it's going to be a multi-year pathway. And that's what we tried to outline in CalAIM, is for the first step is let's get a single contract with a county. So substance use disorder and mental health are one coordinated system, and let's work voluntarily with health plans and counties to where there's willingness to have behavioral health and medical care and dental care coordinated. And then for foster children and youth, let's see if there's any statewide solution that allows us to voluntarily do better than we do now. But again, it's just so hard to predict. I can say based on the current state, we think we can do it, but it's going to take many years and it's slow. But if there's some crisis that makes us move faster, that may shift.
Alice?
I would say from the administration standpoint that behavioral health, homelessness, affordability still remain top priorities. It's not clear, as Kelly was saying, what path is available to us given, you know, the fiscal realities. But certainly I think there's probably consensus across the board that COVID is really, you know, not so much unmasked for all of us on this call, but really amplified a lot of the things that we've been working on. And it's so clear that the current system doesn't work. In terms of the social services part, I know that there's interest in across DHCS, Covered California and CalPERS leadership, for example, to start looking collectively at contracting provisions around things like quality measures focused on disparities, looking at health-related social needs. It's just in its infancy, but I think there's a real interest in figuring out how do we use all the levers at our disposal.
And if we were, you know, we in this cohort, in this fellowship, we've often talked about, you know, other developed countries spend twice as much on social services. We don't do that. So then all of the unmet social needs slam against the healthcare system because they result in profound behavioral and physical health morbidities. So we're willing to pay for them in healthcare. So sometimes I've, you know, thought it seems odd to say the best way we're going to make sure that people have emergency help if they're about to lose their house, like when New York City talks about an eviction notice as a medical emergency. In CalAIM, we've got proposals in lieu of services so that managed care plans have the resources they need to help people with these unmet social needs. You know, if I were designing the building from scratch, would I put those social services in the healthcare system, that arguably the most expensive way to deliver that service? No, but if that's the only thing that we can get the federal pay for, and managed care plans are actually in the position of helping those folks meet their medical needs through addressing the social needs, then we should use every lever we have. So again, echoing Alice, is that we only have a limited set of tools in our tool belt, so we want to use the ones that we can, because paying for medical care while someone has all of these unmet food needs, housing needs, it doesn't make sense. So we have to figure out a better way to do it.
So as the chair of the Budget Subcommittee of Health and Human Services, I actually look across the whole section, I guess in the same way Alice does on the agency side as well. And I think that one of the things, though, that we do, we mentioned it before, is it's very hard to do things statewide because of the relationship between the state and the counties. That's not necessarily a bad thing, recognizing that oftentimes counties are different. You know, you think about Los Angeles versus, let's say, Placer County or less urban county, et cetera. So, yeah, but that does make sometimes some challenges to do something that cuts across the entire state. Then there's the accountability portion. So what happens if a county or a group of counties, you know, doesn't deliver, or their leadership is philosophically not aligned with that as well. So I think that's sometimes, you know, some other back and forth, and we are, you know, so I do think that any sort of advocacy effort should be targeted not only at the state, but also at the respective counties as well, because I've seen too many times where we pass something at the state and we kind of like leave it to the county, and many counties do it, but several other don't. And then we're stuck with this kind of patchwork as well. And so as we think about these policy solutions, I think that, you know, as advocates, we got to think about the different layers that we have to act on to make these things happen. So let's move on then, because we're sort of coming toward the end of our time. Shira Shavit, did I pronounce that? If I pronounced it wrong, sorry.
Hi, it's Shavit. It's okay.
How do you pronounce your name?
You're a Shavit.
Oh, Shavit, sorry.
Yeah, it's not easy to get. So I just want to thank the panel, first of all. I'm sorry I don't have video. We had a cancellation of our daycare. Someone had a fever. You all know how that goes. But I just want to thank you all so much. I mean, it's really insightful, really helpful. I'm a academic at UCSF and clinician. I run the Transitions Clinic Network. We provide healthcare services in the primary care setting for people coming home from incarceration. And you know, really trying to take what is an evidence-based model of care and disseminate it across health systems in the state, and then also elevate it on the policy level. So kind of, I want to thank the panelists because it was very insightful, very helpful, kind of this idea of kind of elevating something from the community in a policy way, but then also realizing, you know, this idea of a window. And I'm realizing I still have a lot to learn and that the window is opening now. So my question was actually to the participants on the call to see if there was anybody who feels that they've been successfully or has been able to successfully elevate an innovation that's evidence-based that they created at the community level to a policy level without it being changed significantly. And I would love to know if anyone feels like they've been able to do that and if they might be willing to provide a little advice to a new CHCF fellow in cohort 2019.
Well, let me, I'm going to go ahead, if you don't mind. I'm going to start with this one and then pass it on to my fellow panelists. So I heard you say not changed, and I want you to sort of back off from that a little bit, right? So let me just give you an example. So I worked on vaccinations. I can point to a whole bevy of different things that actually, well, one of the things I worked on when I was first, before I got into the legislature was getting more kids' health insurance coverage. In fact, we have fully implemented, essentially, we have about 98% coverage for children in the state of California. We have all the undocumented children covered, et cetera. So we achieved that aim. And, but let me just talk about immunizations because what you need to do is keep in mind what your policy goal is and be willing to be flexible, because this comes to building coalitions and neutralizing the opposition, all right? To move it through that window is to keep in mind what your actual end policy goal is and being really flexible to, as long as it keeps moving in that direction, to be willing to accept modifications, changes, et cetera, right? So I want to just bring that up because sometimes people say, I have this pure idea and I want to try to move this pure idea all the way through. And I think that you need to, that can get you in trouble if you think of it that way. What you have to think is, I have an end goal, right? The end goal is to get every child healthcare coverage, right? Or the end goal is I want to, you know, basically get our immunization rates up to 95% in all our schools, right? And then you say, okay, well, you know, people are going to push back and say, well, I want this or I want that. I said, well, if that doesn't stop me from getting there, then I should really consider making that modification, right? And then as long as they agree that they're going to stop their opposition, right? Maybe they won't be for it, but they won't be opposed. And I think that is something to think about, is like, what is the goal you're trying to get to? What's your policy proposal to do that? And then how do you get the political will to move it forward? So it goes back to sort of a framework that I learned from Julius Richmond, who was a former Surgeon General, Health and Human Services, right? You have the data, right? We're all good at the data part. You have the social, you know, your social policy goal, and then you have the political will. And the political will does require that you be willing to negotiate and modify and so forth. But as long as you keep in mind what the end goal is and you get there, that's what you want to try to do. So
if I could build on that, because CHCF leads this remarkable intervention that deploys community health workers with lived experience of incarceration and integrates them on primary care teams so that they truly function as a team member. Beautiful model. And when I was at CHCF, I worked to try and help her scale that model with some other CHCF teams. It should be everywhere, because especially now when we're having a lot of prison releases and jail releases with COVID, we need to have robust transitions so people can land in communities and have these cultural broker navigators help. And you're right, Shira, that's a great window, because there's a lot of conversation about peers and what peer type providers can do and how to make sure that we're taking people with lived experience and getting them integrated on teams. But there's such a tension between a beautifully designed and executed model. Like I think our colleagues Ann and Alan and Ann would agree, like this beautiful model that you've developed at Stanford. How do you get that to scale? Because anytime you move something to scale, then you have to make these compromises about what are the core parts of the intervention that will, if you lose them, the model will fail, and what are the pieces that are nice to have, but that just will prevent you from going to scale. And so I love what Richard's saying is, if you think of the end in mind, that is every person leaving incarceration should be able to have a cultural broker help them navigate the system. You know, what are the components that are the key components that you can never give up on, and what are the ones you'll compromise on just to allow you to get to scale and get to your end goal. I'm excited that you're a part of the fellowship and you're thinking about these things.
Thank you so much. I mean, I really appreciate that, you know, and in that perspective, you know, I think because we've been able to disseminate this to 45 sites in 14 states in Puerto Rico with 21 sites in California, we really know what that core is. And so I would love some assistance in how do you protect that core? You know, how do you move this through the policy piece? And I think we're very clear on what we can adapt, what we're willing to give up, but what if we lose, we'll lose really the outcomes that we know we can get with this work. So I'm curious, is there anybody on the call who feels like they can provide any assistance?
Just given our time, maybe we should talk offline about more specifics about your program. Alice, did you want to make a comment?
Hi, Shira. So nice to hear your voice. And I'm going to share with you, well, you already know Margot's work, but I would just hold her up as an exemplar of someone who, you know, has been working on homelessness for many years, decades in San Francisco, helped stand up, you know, Respite with the whole team, including Michelle Schneiderman here in the call. And I think that model has been picked up and funded through different venues, as well as, you know, some of her programmatic solutions in San Francisco. When COVID first hit, she was in the SOC with us, with our director of DSS, trying to shape homeless policy based on, you know, her programmatic work in San Francisco. So I think, but I do think that the truth is, if you've birthed a great program, there's only so much control you have over it as you scale it. I mean, it's kind of like, I don't know, I guess I shouldn't say it's like your kids or whatever it is. Like, you know, you put it out in the world, and then, you know, it's going to adapt, and it's going to be maybe like an EHR might be a better example. People are going to have their own instance and adapt it to their own needs.
I guess the question I just, and then we're going to have to move on, Shara, is that when you think of, you have your program, but think about from a policy point of view, what are the policy components you need to allow other people to build similar programs like yours and facilitate that, but not necessarily try to dictate in policy exactly how they're going to do the program. Is probably a better way to think about the policy piece of it. And then, you know, you can help other people actually develop the actual program as long as there's a policy framework that will support it. So that might be how you might want to think about what kind of policy changes you want to allow to support your program.
Thank you so much. This is very helpful.
Yeah, but happy to talk to you offline about that as well. I see one hand up. Renee, you have to tell me, do we have time or not? Or
we have about 3 minutes left
okay.
before the end. I don't see the hand, but.
Okay, I see Carlo D'Antonio, and we literally only have a couple minutes, so Carlo,
okay. Thanks. I'm sorry, it will just be brief. You know, thank you, everybody. And I'm a pediatrician. I work with early intervention in the Department of Developmental Services Regional Center System. And I just wanted to bring the comment about the synergy between how the COVID pandemic has its implications in other areas of social service delivery. You know, the state's really seeing a decrease in referrals for children to early intervention, as well as decrease in referrals for developmental disability services, because most of those referrals come from primary care pediatricians as well as from the schools. And when the kids aren't in school, those developmental issues are not being brought to families' attentions. You know, they might think it's normal because their kids at home and they're not interacting with so many other people. And so some of those issues aren't coming to the attention. And also when children they're not going to their well child visits as they were. And that's, you know, a barrier to families getting those developmental screenings. So I just wanted to bring that up as the implications as this health crisis is rolling on, how that mushrooms into other areas of the social service system.
I guess, interesting enough, I just had an interview with a reporter earlier this morning who was asking about what do you see in the future. And I do think that with COVID and the impacts of COVID, right? The decreasing in-person visits, decreasing referrals, hospitals having to make adjustments, what we're seeing with unemployment, housing, all this, that we talk about these windows. It is creating windows of opportunity for looking at doing things very differently because people actually had to. I mean, things that people previously said, well, I don't know about this and might not work out. Now people found themselves doing it. And also we need to think about different ways of delivering not only healthcare, but also other services as well. And then also how we identify people. So certainly we have a lot of opportunities to think about coming down the line. And I know I'm sure Alice and Kelly are working very hard on many of those, trying to figure out how we navigate that. And certainly we're thinking about that in the legislature as well. Any final comments? I know we're literally at the end of our time, Alice or Kelly, before Renee yanks us all off the Zoom.
No yanking, just sincere gratitude for all three of you for jumping into this with all of us and sharing your knowledge and expertise and candor with this group. Really appreciate it. We will leave open the Zoom if people want to informally connect the next session, and Betsy's going to lead us through mindful movement starting at 2 o'clock. So feed yourself, take care of yourselves, and we'll see you again then. So thanks so much.
All right. Well, thank you. And thank you for the privilege of being able to moderate this fantastic panel with Kelly and Alice. Thank you very much. And I look forward to talking to two of you with a minder in the future.
Thank you.
Oh, thank you. Mm-hmm.